Continuing mobile education for emergency medical services providers. This is Procedures in Geriatric EMS, Episode 4, The Evaluation and Transportation of Suspected Hip Fractures. At the end of this episode, you should know the epidemiology of hip fractures, understand the morbidity and mortality associated with hip fractures, understand key physical findings in hip fractures, and understand the considerations needed when transporting a patient with a suspected hip fracture.
The lifetime risk for hip fracture for a woman is about 1 in 7, which is higher than their lifetime risk of breast cancer. The lifetime risk of breast cancer is about 1 in 9. So actually the lifetime risk of a hip fracture is higher. If you look at all osteoporotic fractures like spinal compression fractures, wrist fractures, is much higher. Also the death rate from fractures, or at least let me rephrase that, if you take all folks who have hip fractures, about 25% of them pass away within a year. So if you look at the mortality associated with hip fracture, it's actually higher than breast cancer. We don't have any ribbons for hip fractures, but the overall risk for osteoporotic or hip fractures is very, very high. There's a large number of risk factors for hip fracture. The most common is being female, and then age is also a predisposing risk factor. In fact, the risk of hip fracture rises exponentially after age 65, and then osteoporosis is obviously a risk factor also. The thinner your bones and the frailer your bones, the more likely you are to fracture. That's also increased by whatever your risks for falling are, which can be increased by things like visual impairment, hearing impairment, and also from other medical illnesses like heart disease, stroke. Those sorts of things increase your risk of fractures as well. So hip fractures generally happen in sicker, frailer, older individuals, and they happen more often in women than in men, happen more often in Caucasians than in African Americans. The environment you live in also can be a risk factor. Loose carpeting, poor shoes, small animals, debris, anything that can get in your way and increase your risk of falling will also increase your risk of hip fracture.
1 in 7 women will suffer a hip fracture. That's higher than the incidence of breast cancer, and approximately 25% of people who sustain hip fractures will die within 1 year. Risk factors for hip fractures include female gender, age greater than 65, underlying osteoporosis, visual or hearing impairment, and living environment risks, such as throw rugs or extension cords.
Only about 25% of patients get back to their original functional status. About 75% of patients have some ongoing disability or decline, and 20 to 25% of patients will end up in long-term care after a hip fracture. So a hip fracture is what we call a sentinel event. It's a statement. Just the fact that they had a fracture is a statement that the patient has other complications and may not do well. Probably the most important complication that we think about is thromboembolic disease, or DVT. So DVT stands for deep venous thrombosis. A deep venous thrombosis can break off and become a pulmonary embolism, and that can cause sudden death, can cause shortness of breath, and can cause other complications. So that's the one really big complication that we're very frightened of. And almost all patients that have hip fractures get some type of prophylaxis against thromboembolic disease, usually warfarin or low molecular weight heparin. So almost everybody will get some type of prophylaxis for clots. The other complications that can happen are infections of the wound, breakdown of the wound. The wound can open up. Sometimes people can get infections of the prosthesis that we put in, the pins or the other parts that we put in can get infected. Those are very serious complications also.
After a hip fracture, only 25% of patients will regain their original functional status, and 20 to 25% of older adults will require a nursing home placement after a hip fracture. Post-hip fracture complications include deep vein thrombosis, pulmonary embolism, skin ulceration, and wound infection.
Suspect a hip fracture in the fall of any adult over the age 65 or 70. You just need to begin to think that even if they're not complaining of any pain in the area of the hip, you need to suspect it, and you need to assess carefully for it. The key physical findings for hip fracture. I'm amazed at the number of hip fractures that get diagnosed at the nursing home from the portable x-ray, and then they call EMS. So this is a person who will have fallen overnight. The staff at the nursing home moves them back to the bed, calls for the portable x-ray in the morning. Portable x-ray shows up, takes the picture. Later in the day, it comes back, yes, they fractured a hip. Now let's take them to the hospital. So, and what amazes me about that is that the signs for it might be so subtle. The external rotation is just so slight, and the pain is just not really there during the assessment, that it's difficult to detect the minor hip fractures some of the time. So it's can be a very subtle injury, and you need to have that high index of suspicion. Anytime that a family member reports that they seem to have more difficulty walking than before, how could a person walk on a broken hip? They can, particularly if it's a small fracture. So that's something that you need to keep in mind and have that very high index of suspicion. It's really any fall, any kind of pain near the hip. Classically, we talk about the hip being, or the foot being internally rotated for fracture or dislocation, and externally rotated as well, as opposed to being straight. Does it matter whether it's a dislocation or a fracture? No. Pre-hospitally, we're going to treat it the same. And so you want to look at the feet and make sure that they're going in their natural anatomic direction. If there's any variation of that, we need to suspect that we may have a hip fracture. And just remember that the older and more brittle they are, the more likely they are to have a hip fracture.
When EMS arrives for a patient with a risk for a hip fracture, most of the time it'll be obvious. Usually the hip will be externally rotated and the leg will be shortened. So that in and of itself is a very obvious sign just on first observation. The other important clues on physical examination is that a patient who is demented and won't bear weight should be considered to have a hip fracture until proven otherwise. So they may not have any displacement, they may not have any rotation, but they usually will have tenderness.
You should suspect a hip fracture in a fall of any older adult, and a hip fracture may present obviously or more subtly. Important hip fracture physical findings include an outward rotation of the leg on the injured side, shortening of the leg on the injured side, an inability to bear weight, and tenderness over the hip.
Hip injuries, it's interesting to look at the textbook description of what should be done for a hip injury. And they'll talk about putting a person on a backboard and having them very well padded. Some of them will describe a very long splint to go around the leg. And then we look at what is often used in the field, where the patient will just be moved with as little movement as possible. So if they're found on a nursing home bed, well, we'll perhaps secure the legs together, either with sheets or cravats, and then we will very gently pick them up right on the stretcher, or right on the sheet, and move them to the stretcher. And you won't find a textbook that endorses that. But when you think about what are we trying to do, we're trying to limit the movement as much as possible. What kind of movement might we be doing with a log roll and getting that person on the backboard? What kind of pain are we going to inflict on that patient when we put them on the backboard? So that's something to consider. Our goal, anytime we're treating a suspected fracture, is limit the movement of the extremity. How best to limit the movement of the hip? Perhaps it is the backboard. Perhaps it is the scoop stretcher. Perhaps we can succeed in limiting that movement just by securing, splinting the legs together and being very careful as we move them, having an awful lot of hands available to move them from one place to another.
Perfect.
Another point of preparation for the patient for transport is that we need to make sure that we manage their pain. And this is an isolated extremity fracture, and they're likely to be in a fair amount of pain, and morphine is probably indicated. We want to see what other medications they're on. We want to make sure the rest of their health is appropriate before we give it. It might not be a bad idea to consult with medical control to treat before we give the medication, but it is certainly appropriate for us to give the patient morphine before we move them and before we transport them, because even if we do everything as perfect as possible on the move and the transport to the hospital, it's going to hurt every time we hit a pothole. Transport of a patient with a suspected hip injury, we do have a fracture that we're concerned about, so we want to limit the movement of that extremity as much as possible, understanding that we don't want to create an injury as we're doing the movement. So if we're going to put them on a backboard, which is an appropriate way to treat this suspected hip injury, we also want to pad that backboard. Maybe we actually put them on a blanket and then put the blanket on the backboard to help hold that hip still. Same thing if we're using a scoop stretcher, an orthopedic stretcher, that we want to keep that as still as possible and make sure that we're not going to create any injuries, any pressure sores by putting them on too hard of a surface. And again, managing the pain before the transport so we're not increasing the trauma to this patient and making sure that we take care of them in that manner.
Well, obviously, when you transport a hip fracture patient, you want to be very careful to manage their pain. Pain can lead to all sorts of complications, including confusion and distress. When you are in a lot of pain, it activates your fight or flight mechanism, can increase your heart rate, increase your blood pressure, can actually cause heart attacks and strokes. So we want to treat people as gingerly as we can to keep them comfortable. So using the usual techniques to keep their hips stable while you transport them is very important. Trying to keep the patient calm, and where appropriate, giving pain medication in the field. We really encourage the idea of treating people with pain medication prior to transport and transporting them as comfortably as possible to minimize the risks of activating their fight or flight mechanism. And we've worked with the EMS control at the hospital to be liberal on how we manage that pain medication and gave them good guidelines. So you should be able to call in, if you're transporting a patient to Highland, you should be able to call in and get authorization to do pain management right in the field. And that's really probably the most important thing. People do bleed into hip fractures, so trying to keep the hip stable while you move them can minimize the bleeding and minimize the pain.
To more comfortably transport a patient with a suspected hip fracture, stabilize the affected hip prior to transport. Use IV analgesia prior to transport, limit the movement of the patient, use plenty of padding, and get additional trained hands when moving the patient. After viewing this episode, you should know the epidemiology of hip fractures, understand the morbidity and mortality associated with hip fractures in the elderly, understand the key physical findings of hip fractures, and understand the important considerations when transporting a patient with a suspected hip fracture.